All right. Well, Cynthia and I and Matt were just lamenting that it's probably the toughest act to follow, magician and a humorist, so or a comedian. So we'll do our best to see keep you entertained as well. Cynthia, would you? Oh.
And Tina's going to steal your watch.
Cynthia, would you like to start with introductions?
I would really enjoy starting with introductions. I am Cynthia Davis, and I am an executive consultant with a clinical background with Healthlink Advisors, and which is based out of Tampa, Florida, and I've been doing health informatics and care transformation and innovation work for the majority of my career. I'm a nurse by original training. But I always like to say I spent a large part of my career bossing and growing CMIOs as those roles came into fruition. I'd like to introduce Tina Burbine as well. She's our VP of Clinical Innovation at Healthlink Advisors. Tina has a very deep level of expertise, both in care transformation and in data analytics. She's a native of, or she lives in the Phoenix area, and I always enjoy hearing about her adventures between the joys of Phoenix and the joys of Flagstaff. And then we are very pleased to have Dr. Matt Anderson. He is a clinical leader and with the Banner Innovation Group, and he's gonna support and be part of our and really a conversation today about care innovation and hospital at home. And so when Tina told me today that we were going to be following, a magician, I thought, oh my gosh, what are we going to do? I mean, and then she told me we're the last thing or the last chat before the last keynote and then happy hour. And so I thought, oh my goodness gracious, how are we going to keep these people engaged? Well, I was thinking about that, and then I stopped in at CVS to pick something up on my way to get ready for this presentation. And I happen, I don't know how many of you have been at CVS lately, but if you happen to put in your information, you get these horribly long receipts. And so I got to thinking, I don't understand how Jeff Bezos is richer than the person who sells receipt paper to CVS. So hopefully I didn't get too many groans for that attempt to add a little bit of humor. Tina, you want to take it away?
Yeah, we're happy to have a talk today because this care at home transition that we're all starting to see across the industry is pretty prevalent. So we're excited to talk about what does hospital at home mean, because everybody definitely defines it uniquely. Why does it matter? Why is everybody jumping into that? And then of course, what do we need to do to be ready? And we're very grateful that Dr. Anderson was touching on the culture of innovation this morning, and he was willing to join us this afternoon because that's such an important part of any new care model that a health system or payer team is tackling.
So I'm going to talk a little bit about what hospital at home is, and then we're going to actually, as we go through this, walk through some use cases and some different examples. But many of you have probably read or seen in the press or maybe heard some other presentations about the emerging care transformation or care innovation model called hospital at home. So I'll tell a story because I had a 95-year-old, very independent mother who was living at home in Michigan, and I was residing in Florida at the time. She was trying to remain in her home and not have to go into assisted living, and all of her children were living across the country, which I would assume in Arizona you have a fair amount of those folks who are snowbirds or have family members that live in a lot of different places. So it got to a place where she started to have a lot of different readmissions. Oftentimes they were for some things. She had a bit of cardiac disease, so she had a touch of congestive heart failure, but she would show up in the ED, and then she would have to go through the whole process of getting admitted and often having like maybe a day or two of stabilization. It was later in her care process and her life journey that the hospital that she received her care at began a hospital at home type program. And what that meant for them is that she was able to get acute care in her home. And so when she had episodes where she might be retaining fluid or, starting to have a little bit of congestive heart failure, the hospital at home program would come out and they would care for her there. And it would combine, all of the things that we think about when a patient is pre-hospitalized, both in the acute care and the ambulatory care setting. Dr. Anderson, anything you'd like to contribute or clarify on that front?
No, not really. I mean, I think when we think about home, I think there's so many different applications of that and caregivers. So I think the part of that home definition involves who's going to be doing some caregiving as well. So I think that's the other component there. But otherwise, no.
Yep. And a hospital at home looks like, and it's a very much a criteria-based, provider-led episode of care. And certainly you can only, you can be admitted. And in my mother's case, oftentimes she would contact her physician's office. They had a telemedicine capability. And she would actually go up to a monitor and press a button and be connected with her care manager or a nurse in kind of a 24-hour bunker that could talk to her. And then her physician, after assessing, getting the information from the bunker, would assess whether she would be eligible for receiving care at home. And other opportunities in it are that when patients also show up at the emergency room, and I think of a use case of a client that we work with now that is using a very proactive process so that when patients arrive and are admitted into the ED and initially triaged, that information is sent via cell phone to a care manager who goes in and looks at the record. And in that instance, they're really much looking at patients who are at high risk, high utilizers, or someone who's at emergent risk. And then pulling their information, going and speaking to the provider who is going to be assessing them to say, hey, I know this person has been in a great deal. Looks like their stays are, pretty brief and short. Might we, as you think about where the next level of care should be, can we maybe consider using a hospital at home program or one of the other services? Patients also need to be examined by a physician in person prior to beginning that at home. And then really it's a patient-centered program. And so of course they need to agree as to whether they would want to have services delivered in that method. And of course, you've got to have a safe home environment. You've got to have someone who can, in some instances, help with translation and support as well. But the data says that patients who are getting this kind of care are really seeing some really great outcomes, lower cost of care, less falls, less confusion, as well as just general overall patient satisfaction. And we've got now with clients, patients are actually, asking to be, can we be considered for these types of programs? And so as you're beginning to think this through, and we will talk about this a little bit more, it really is something that our consumers, our families are beginning to ask for. So a question Tina and I often get is, well, isn't this just plain home care? Why is this any different from just sending a home care agency out? Well, it starts with, and Tina, if you could go back for just a second. Thanks. If you could, go back and, start with the extended care, you obtain, certainly a set of vital signs. You may have an opportunity to have certain different diagnostics and treatments, whether it be EKGs or echocardiograms, pharmacy services, and then potentially you might have some remote monitoring. But it is intensive acute care in the home setting. And so an exciting way to help transform the experience for our patients, and certainly a satisfier for our providers as well. Dr. Anderson, any comments on this slide as well, or any contribution?
No, I don't. I think that's a pretty detailed slide. So.
Okay.
Yes, please. We have a question, Cynthia.
Sure.
Because that first bullet on upper my left, patients can only be cleared for hospital at home after being admitted versus permanent, which I completely understand for the inpatient hospital settings. You could actually run into a scenario where somebody's inpatient admitted and then they're like, this job's come, like go home.
Yep.
It seems like a necessary step and kind of a patient dissatisfier. I mean, they'd love to go home, right? But they're like, why did I just spend the night here when you could have done this to me yesterday, right?
Yeah.
I think it's probably just an evolution of where we're at with this model.
Absolutely. And, it's funny that you mentioned that, because for health systems who are starting with these programs, the level of acuity in terms of the type of care is going to grow incrementally as well. And that's actually also tied directly to how you create a financially sustainable program also. So yes, we want the patient at the center of care. Yes, we want to do what's best for them, but health systems more than ever, or payer teams that are getting involved with this, need to make sure they're making financially smart decisions, especially after the last year, right? So to your point, that actually parlays into some of the value-based care arrangements. So even though we are defining hospital at home as true acute level care based on the CMS criteria, because yes, they announced new funding in November of last year to cover acute style care in a patient's home, your hospital at home program should care for patients in a more broad way as well. So think about your value-based care physicians and how you can leverage this to help your patients stay healthier longer in those performance-based arrangements as well. And of course, as Cynthia always says, I'm very, maybe I'm too money focused, but I think there has to be that balance, right? So some of
No mission, no margin.
No mission, no margin. And so that's what, when we think about the changes that have happened, the trajectory finally led us to this place where CMS said, hey, we understand the value of this type of care. And because of the pandemic, we now have dollars behind it. So there's a real opportunity to leverage that. CMS created a fast track attestation process. It's very easy for health systems to walk through. And most health systems at this point, majority of them in the US have attained CMS approval for this, but just because they've been approved doesn't mean that they actually have the foundational elements of the program in place. In fact, we're seeing that many are struggling to figure out, even though they were able to talk to the care plan, to actually operationalize it, whole different level of complexity. So you combine those things along with the fact that, we've got folks now in this consumer-driven market who want to be cared for at home. So in the markets where patients understand that this is starting to exist, they're asking for it. And so it's created this new level of competition with the payers jumping in and the health systems trying to jump in, and somebody in the market that they live in is going to be able to provide this type of care. So we want our health system leaders to be prepared for that so that you're able to continue caring for these patients, whether it's in their home or otherwise, instead of having them look to somewhere else to provide that. Let's see. When we think about hospital at home, this sounds so innovative, right? But really, it's a standard of care everywhere else around the world. This is very, very common. And it's only in the US where we've started to finally actually have some dollars behind supporting this model of care. The data has been in existence that shows there's a, between 35 and 40% lower cost of care, like Cynthia mentioned, for years. Johns Hopkins did this study back in the early 90s. This concept has been out there, but it's only, it wasn't until November of last year that there was finally reimbursement opportunities. And that has actually driven a change in the way the payers view this care as well, and they've gotten on board. So for those health systems that have any at-risk contract positions, they're willing to now come to the table and renegotiate with their payers for both investment money and renegotiate the kinds of populations that they have at risk using their hospital at home care to help support those patients.
Yeah.
When we think about the financial impact on a system as they begin to develop this type of program, we know that when you consider the impact on your value-based care savings, and the DRG code-based reimbursement that's available for CMS, and you combine those two things, that's a pretty strong revenue stream that's going to ensure that as you're caring for these patients in their home with this whole new care model, it's financially sustainable. That's when we think about the ramp up time. So we're going to get into talking about how to actually establish a program operationally. But when we talk about, okay, to go through the steps of attaining your CMS attestation, being granted approval to obtain that reimbursement, meeting that criteria, don't stop there. Focus also on layering in the things that you can immediately impact to help improve outcomes through hospital at home as well. And it's those two things combined. If a system chooses to only obtain their CMS approval and grab those DRG code-based reimbursement opportunities, it's not going to be enough to create a program that's meaningful from a financial standpoint to a system. You've got to think, a team needs to think broader than that. And that's really important to understand when a team is thinking long-term about being able to continue providing care in the home for patients, not just over the next year, but for the long run. A lot of systems started out thinking that they were going to use this to support patients during COVID, but the intention is much broader in terms of conditions and treatments that are available.
Like I saw that there was this idea that you had to measure the vitals 2 times in a day. Now even the pace with which telemedicine and telehealth is going, we have constant remote patient monitoring. And how much the component of telemedicine is going to be incorporated. We are in a model where one physician in an outpatient setting has to see 30 patients to break even their salary. So how are we going to think about physician visiting in person or incorporating telehealth? Because that model seems like how you're going to scale it seems, unless you use pay components.
Yep. So in a hospital at home, in any kind of care at home program, a team's going to create air traffic control, and it's going to be comprised of different shared resources across the organization. So you may set up a per diem situation with some ED physicians providing coverage, on a daily, nightly rotation kind of basis, right? But to be out in person, you may send out a field paramedic or somebody, if we're in a state where a field paramedic certification program doesn't exist, and believe it or not, there are still states, particularly in the South, that struggle with that. You can set up a different operational approach that leverages a little bit different skill set, still get somebody out at a lower cost to the health system into the home while virtually connecting the appropriate level of clinical support that's needed, whether that's a physician, RN, LPN, nurse, whatever it may be. Yeah.
They partner with existing home health companies, or they create in the health system to
For those who are online and may not have heard that, the question is, are there external partnerships being created to help support this? And that comes back to that age-old question, build or buy. And that's where establishing a cost model is so important at the early stages of a health system evaluating how they're going to manage this. If you're going to build it, there are obviously some existing operating costs that you've got to keep in mind. But in order to approach that as efficiently as possible, our recommendations is that, yes, you should be resource sharing. So when you think about the home health teams that exist, this is not the traditional home health type of care. It's very, very different. But because you've got a collection of team members who understand what it's like to be out in a home, which is culturally very different than our ED physicians and our post-acute care teams that we also want engaged in this, if you're successful at bringing those teams together and incorporating this cultural shift to understand how this care model can work, a team can be very successful creating that internally. Now, if culturally there seems like there are too many sensitivities there and an organization wants to move fast, they may decide to partner with somebody while they build this internally. Now, I will offer that from a financial perspective, the vendors in the market these days that offer outsourced models are also taking a distinctive revenue share from that care that's being provided. So that's an important component if a team is evaluating the cost model to drive a build or buy decision internally about how to tackle this operationally. Sometimes it's as high as 80%. So in a health, exactly, I see eyes going up like, wow, it is a very high number. So it's very important that when a team is going to tackle providing care in the home, be thorough and incorporate cost modeling into the decision-making process as early as possible. Yeah. Cynthia, would you add anything to that?
No, I think, and again, it's, you know, every organization is different. And so you really need to understand your providers. As Tina said early on, understand whether you're going to make or buy decision, and also really begin to engage your providers, because this is, and I mean providers and clinicians, because this is a very, it's a different way to provide care.
So we have one quick comment I'll make before we keep moving forward here. You know, we can't say this enough, that there is this traditional, been in existence for decades, home health model. That is very different than what we mean by hospital at home. But if you're able to incorporate your home health teams into any kind of new care at home models, you will be able to also maximize the revenue that's affiliated with the care delivery through the CMS reimbursement, your at-risk contracts, et cetera. So it's bringing all of those things together.
So I always like to begin, and as we work with organizations across the country, you've got to start with your strategy. You really need to be thinking about at the very highest top, the top of your organization, what's the vision and what's your mission? And so bringing your executive stakeholders together and creating a vision and mission and a core team. There are lots of opportunities in health systems across this country as you're thinking about care that crosses the home, the practice, a PHO, an ACO, and acute care settings, SNFs, community resources. There's lots of different care team members that are working on very similar goals. Oftentimes when we come in and talk to organizations, we find, you know, we hear, oh, we don't have enough case managers. Oh, we don't have enough folks to help with the transitions of care. I think of an organization we worked with quite recently, a very large IDN, and not enough coffee on a Friday afternoon, large IDN, and they had over 250 care managers in their 6-hospital health system, and found that many times everybody was running towards the same problem, and patients and families were getting multiple reach outs and multiple phone calls saying, you know, have you made your first appointment? Have you followed up with this? You know, what are your medications? You know, what community resources that you need? And patients and families were saying, you know, who's really in charge, because so many people are reaching out to us. So we find it's really a very important step to do an assessment of your current state of your care team structure and process and people. What are the things that you're focused on? In many organizations, it's clearly Medicare shared savings. It's also Medicaid, managed care contracts. And so making sure you've got your teams, and then begin to put together a common set of roles and responsibilities. Some care management teams are very UR focused. Other care management teams are more proactive. So create a vision and actually clarify roles and responsibilities as to how your care management teams are going to work. Break down silos. And a lot of that is cultural innovation. It's, you know, calling the question, how can we make sure we're really working as one team? And one thing that I love that certainly in large organizations or organizations that have a comprehensive EHR that covers acute and ambulatory and potentially home care is, you know, you have some technology that can help you with that. So using that, you're going to initiate your program. You're going to determine how you're going to identify patients. You're going to determine a first or second use case, whether it be congestive heart failure or perhaps readmissions, you know, it really depends on your organization and the clinical needs, the business needs in your organization. You're going to create a staff model. As Tina said, some states don't yet use paramedics for some of this work, but you know your team, and there's different ways to skin this cat. This has to be a clinically driven protocol model. You've got to set up criteria for who's eligible to be entered into the program. You've got to have a design in which there's a rapid decision making for when patients show up and potentially need this care. It can't be something that, you know, it takes 2 or 3 days. It's got to be, you know, immediate, using that hub concept that Tina spoke about, making those decisions. And I always like to say, you got to begin with the end in mind. What are the measures of success that you're working towards? You can set up these programs, but if you're really not driving towards outcomes of, you know, a reduction in cost per case, a reduction in falls, in, you know, making sure your clinical outcomes and patient satisfaction are high, then, you know, I think it's not a good use of our health system and patient and family resources. And then you go. And there's a lot of work that has to happen across these different multidisciplinary teams, whether they be in home care or the acute care setting, or in, you know, an ACO or PCO or the practice. You've got to work through your operational workflows. How are the handoffs going to happen? Where are you going to get your supply chain item? Who's going to do the medication reconciliation? And then you need to report out. And most importantly, these days, we're beginning to see many payers begin to establish these programs. And so determining what your approach is in your organization with partnering with payers, you want to compete with a payer, or is an important conversation and a strategic focus across the organization as well.
The biggest hurdle is building a culture of innovation, because from our perspective, we're talking about building care at home now, but in 3 years, we're going to be talking about something else that's new. And so creating a culture internally that supports your clinicians and physicians and administrators and non-clinicians to all understand, you know, it's okay to work iteratively and to fail fast and to do all of these things that we know are agile in nature. But boy, that can feel very, very challenging when you're working to pull in home health, who thinks one way, and acute care, who thinks a particular way, and post-acute, who is not used to dealing with the acute world at all, who wants to, you know, send. So Dr. Anderson, I'd love for you to jump in and talk a little bit more about that framework. You shared a lot this morning, and it's so relevant to all of this.
I see some familiar faces too from this morning, so thanks. Yeah, you know, a couple of things I was thinking about as you guys were talking about this is, one is sometimes I think hospital at home has this we have this image in our head of the little old lady with community acquired pneumonia who, you know, just needs to lay in her bed and get some IV fluids for a week. But I think there's a lot of other opportunities for hospital at home, and I think when you start, and Cynthia, I think you mentioned it, start with the end in mind. I think you start with the patient end in mind, right? So one of the things we're actually working on in our innovation group is thinking about how that high-risk pregnancy works at home, right? The high-risk pregnancy that potentially may have had to be in the hospital for a period of time, especially closer to delivery. You know, how does that obstetrical experience go? Or if anybody has kids in the here, you know, now pre-COVID world where everybody was getting like gastroenteritis, you know, there's a situation there. I have 2 boys who are 9 and 12, so gastroenteritis is not uncommon in my house, right? So, you know, being able to treat those kids at home, right, or be able to skip some of that needed triage can just speed that up. So thinking about that patient outside of the little old lady with community acquired pneumonia, I think is really, really important. The other thing I was mentioning, you mentioned sort of like the idea of MVPs and fail fast. You know, we were talking about this morning, that's really tough for a lot of physicians and any clinician, right? So nurse practitioners, PAs, RNs, anyone. It's really tough sometimes to think about those things. And this is an absolutely true story. Thinking about an early hospital at home program, we got a whole bunch of people together, a whole bunch of physicians, and we said, you know, hey, what are the criteria, right? What are the criteria? And we let them set the criteria. So we thought that was a way to get buy-in, right? Have the physicians set some of the criteria. And after a couple of working group sessions, kind of just shut it down because all of the different caveats and all the different permutations of care, like literally no one could be admitted. we had such strict criteria because we just feel so conservative. We talked about it this morning, like perfect can't be the enemy of good, you know? And so we had to kind of reset and get some different voices in other than just the physicians, because you have to be able to overcome that inertia, that conservative nature of a lot of clinicians. So, you know, and the other thing I was going to mention is that just the tools that we have, one of the biggest hindrances to, and I think you mentioned a little bit about RPM, one of the biggest hindrances to doing real hospital at home is we don't have the tools that we have in a hospital, right? We don't have the tools, but we're getting there, right? We're getting there. So connected devices, connected stethoscopes, right? Where you can do, where you can listen to the heart, listen to the lungs, and do a 1 lead EKG all remotely. That's pretty fantastic, right? We couldn't do that before. That's really wild. I saw, I do judging for the UCSF Digital Health Awards, and I saw this really cool technology. They are building essentially on the idea of like continuous glucose monitors and insulin pumps, like subcutaneous injections with massive amounts of fluid, right? So instead of doing home IV fluids, it's a little clamp that you put on, you stick the little vial in, however many liters of saline you need to add to it, and it just slowly goes into your body. So there's no IVs, no hanging, no nothing. So it's pretty fantastic, right? So the tools that we're going to have soon are really going to change how we do it, because a lot of times when we say hospital home, we're literally thinking about, well, let's put a gurney, and then like let's put the IV pole, and let's put the blood pressure cuff, right? I see heads nodding, so that makes sense, right?
So I think what happens is that right now hospital means that what is the criteria, and you have to be sick enough to get into the hospital. But when we are looking at hospital at home, we want to intervene early so that you don't end up so sick you have to get to the hospital. So either we have to kind of, somehow change the terminology, or this cultural shift that you have to intervene early.
Yeah.
Because a lot of people will say, why are you calling this hospital at home? This person is not sick enough. Because, the world we live in before COVID or is like that you have to get sick enough to come to the hospital. We are talking about something which is, how to catch them early. So you stay at home, get better, and learn better.
Yeah, absolutely. And for those online, what we were talking about was the idea of the hospital at home being the sort of the wrong phrasing. And it really should just be about care at home, right? It really should just be about care at home. And I think you're totally right. And I think as you see less and less importance of the hospital admission, right? So there's like hospital admission criteria, right? You have to be able to meet those criteria to get paid. If we have fewer of those, if you're partnering with health systems, like you mentioned, if you're working with CMS, if you're doing some of those things, our potential partnership for some of our obstetrical work would be an insurance plan, who would like to see better outcomes with higher intensity care, but at home, right, in a less costly environment. Because we do things to you in the hospital, right? Like, we like to do stuff to you. Something's going to happen, or you're going to get a hospital-acquired infection. So, it's hard to get C. diff at home, I think, is what I'm trying to say.
Yes.
So,
Yes, we agree.
Yeah, are you seeing this as a possible alternative to all these sensitive skilled nursing?
Yes, there is such a thing. Oh, I'm sorry, go ahead.
yeah, no, please, jump in. Yeah.
Yes, there is such a thing as SNF at home, but really it's so fascinating that to me, it's not about the label. It's, do you have the appropriate staff in your air traffic control to provide the necessary level of care to somebody in their home? So whether it's hospital at home, SNF at home, whatever it might be, it's exactly, it has to be the most important component of this for a successful model to see the improved outcomes is that you have to incorporate your therapies, occupational, behavioral health, in addition to the actual physical care that the patient needs. Yeah.
And again, it's back to rapid decision making. You've got to be able to be very agile. You need to know, what is the use case you're trying to address? What are the criteria for entry into the program? And I love the story about, starting to look at obstetrical care. I mean, it's a perfect example. It's safe. You don't expose folks to bugs they don't need to be. And I think we're going to see more and more, even, younger patients going into these kinds of programs. They became certainly, I know there's a large IDN in the East that, rapidly launched a COVID at home program. And so when you think about that, it's just, there's so many various use cases, and it really depends on your community, the population you serve, and all the rest. But I think our message also is, don't be afraid to think about innovation, and don't be afraid to kind of poke and look at new ways to provide great care.
I can tell you guys one more funny story. This happened during COVID about telehealth. One of the things that I think a lot of health systems and a lot of physicians learned was that you don't have to keep everybody overnight after certain surgeries. We used to always do that, and now we send a lot of people out because we just didn't want them in the hospital. We didn't have the beds. We didn't want them exposed to other COVID patients. So we'd send more people home faster that way and do some telehealth. And so I worked on our telehealth team during the beginning part of COVID, and one of the things that one of our executives really wanted was to make sure that no one was exposing their genitalia on telehealth. They were just worried about that. That was it's true, right? And I was in charge of training all of our physicians on our platform, and so that was part of the rules, right? Was that you please don't have your patients expose their genitalia. And so, but then I got a very angry call from a pediatric surgeon who said, I hate this. Like, I can't do this. You have to change this rule. What are we talking about? He's like, I have to do acute incarcerated hernias, and kids still have to come into the hospital. I can send them home same day if I can see them the next day and I can look at that wound, but inguinal hernias, I will have to look at genitalia. You can't make me break these rules. So we had to, like Cynthia said, be flexible, be willing to make some adjustments on the fly. And so we carved out for pediatric genitalia surgeries and hernias, you could expose those on camera. So just one of those unique things. I never thought that I would be part of my job was to talk about childhood genitalia on camera, but it was. So
all good.
Something that Dr. Anderson shared earlier was tools, right? Tools have come a long way. The examples he gave, though, are the types of tools that we're using out in the field when we're in the home. Huge amount of innovation. How many people believe that their EHR can support hospital at home right now? And I'm respectful of the fact we're in Cerner land. So who would believe that? Yeah, it's true. All of the big EHRs actually have what I call lightweight workflows for a hospital at home. They were developed for the field hospitals that were set up during COVID. But guess what? That is the same type of documentation workflow that you need when you're sending somebody into the home initially. Mm-hmm. So there's a way that a team can get started using the EHR that they have in place. Now, there's a couple of caveats with that. It does take, while those workflows are available to use, there is some build work there, 2 to 3 weeks on average, right? But that's a small amount of time when you're able to then take advantage of your existing EHR, this additional added workflow, and then you can start building onto that and figuring out who the partners are that you're going to leverage to fill the gaps of what those workflows currently don't do. Traditionally, those workflows currently are supporting, they're based on an inpatient bed build. It doesn't matter if I'm talking about Cerner, Epic, or any of the others. The reason that the EHRs have taken that path is because they're trying to keep up with the changes that CMS made with that reimbursement opportunity. Those dollars are tied directly to DRG code and inpatient setting. So that's how the EHRs got their start in this too. Now we know that the EHRs are going to make great strides in maturing over the next year or two. In the meantime, though, for the teams that are going to operationalize this type of care now, got to figure out a way to fill the technology gaps. And that's where your third parties come into play. You've got to figure out how you're going to manage your patient stratification once you have the criteria defined, however long that takes. You've got to figure out what's your data flow behind all of this, right? In and out of the EHR, how are you going to keep the care teams connected, Are you going to use all the data from the devices that you have out in the field? Those are all things that there are vendors in the market that are doing now, and they can help integrate it into the EHR. But I think it's a really important point to understand some of this exists and it's already available. It's a matter of ensuring the teams know and how to get that built and in place and then build on that so that the teams have the IT enablement behind them to successfully support all of these new care coordination and conversations between the clinicians, the physicians, especially cross teams.
So key areas that organizations should think through as they're moving towards clinical innovation, a culture of innovation, and certainly looking at hospital at home. One, we've talked about, creating a vision, making that cost decision, whether you're going to build or buy. Sometimes folks buy and roll in because it's very easy to, quickly make progress. And, the trade-off is then you're not always capturing or receiving the majority of your revenue that you can obtain if you build and redeploy your many resources. Think about certainly what I talked about in terms of care management. Many organizations have many silos of care management. How can you redeploy staff, not only in care management, but in other clinical areas? Decide what kind of home in services you want and services you want. Do you want to target the OB population? Are you going after the palliative care? Are you with folks with needing sort of very much comfort services who, instead of being in an acute care setting or an acute care hospice, could be could remain at home? Figure out how you're going to staff it. You use nurses? Are you going to use paramedics? Do you have some sort of around the clock air traffic control service in your organization that can be incorporated to leverage and support this? Who are going to be your providers? Who's going to make your medical control decisions? And then, think about how IT is going to enable it. One thing that I'm really excited about, since being in healthcare IT for a couple of minutes, is that we're really beginning to be able to leverage the huge investment that we've all made in the last 20 years in automating our health systems. And those of you who have a platform that allows you to connect home care, the practice, the office, the acute care setting are really going to be able to begin to leverage. But I think also there are certainly some gaps in the core vendors that exist now that may not meet all of your needs. And so I really encourage you to do a good functional gap analysis and make sure you understand, what you have and what you might need to augment in that care process as well. And then, home care agencies are an important component, whether you have a home care agency in your health system or a variety of those in your community. There is a good opportunity to really have a critical conversation with them about what types of service levels that you want to have in order to support you in the program. And then again, as we've talked throughout the presentation, having that, understanding certainly of what your payer, what's your payer certainly doing in your marketplace, and how might you partner, leverage, and actually obtain some reimbursement to pilot this program with a payer. So we have at Healthlink Advisor, we've defined a maturity model that we are delighted to share with you, because it allows you to begin the thought process of understanding, to my earlier point, where are you? Just like, the HIMSS analytics level 7, you really want to understand, what are the steps that you need to take to be able to optimize and provide the right kind of care in the right location. So at the very basics, many of you might just have traditional home health services provided. Some of you, as you're thinking about how to innovate with this kind of a care process, you should begin to think about your vision and your core team. And then you can see, I'm not going to read the slides to you, but really this tool allows you to look at your own organization to say, where are we in this level, and how can we get to where we need to be in the future? And one thing we want to really encourage you is that, again, the payers are moving rapidly into this market. And so we really encourage you not to waste time. You may look at your organization and say, well, we don't really have that much risk. We've still got a lot of fee-for-service business. With the rapid transitions that have happened with COVID, I think payers and organizations have learned that they really need to be very rapid and very nimble in order to get these care delivery processes in place. Dr. Anderson, any additional comments?
Yeah, I mean, I think for me, there's two other things I might tack on to what you guys are talking about. One is just the use of tools, and we mentioned tools earlier, and I think artificial intelligence is one area that for being able to find what's important and being able to sort of blur out what's not important. I think artificial intelligence is really going to push the envelope there. And then we're talking a lot about all the things that you need for this, and so there's a health equity component of this as well. This is really easy when you have a certain type of patient, right? But we have a very diverse population, and so knowing how to be innovative, that's where sometimes we have to be the most innovative, is in what do we do in multi-generational housing? What do we do with people who are not permanently housed? What do we do with people who don't have Wi-Fi? That's a component. So all of these things, and those also tend to be the places where we have contracts where we want to be the most aggressive with, right? So we have our Medicaid and our Medicare contracts. So being able to be very conscious of that from the very beginning. One of the things we talked about earlier today was empathy in innovation, and so that component of health equity, I think, is really, really important. So, and I think it goes. Actually, I think the health equity component goes with our AI as well. So I think there's a huge component there.
Did anybody happen to meet Tab Gary today by chance or run into him? Does that name ring a bell? Bringing it up, he's the Chief Operating Officer for Mercy Care. And we ended up having a conversation earlier today by happenstance about how Mercy Care as a payer, those of us in the state of Arizona are familiar with them, who are starting to work with our city field paramedic teams to provide better SDOH data to them, so that if a first responder, fireman, police ends up in front of somebody who really needs healthcare, behavioral health, whatever it is, it's not a true emergency, we can get them transitioned over to a navigator so that they receive the help that they need and those 911 calls stop. So it redirects our first responders so they're able to better focus on the types of things that they should be there for. It was a pretty interesting dialogue, but those are the types of things when I think about health equity that are really meaningful. And so it's so good to hear that some of our payers here in the Arizona market are very mindful of that and are actually starting to do something about it too. They see the value as well. All right, I want to be respectful. I know there's an afternoon keynote, Drew Tarvin, who is pretty fantastic. But we're always happy to answer questions. So sure.
I've been in a lot of care prevention efforts together, ambulatory acute and health starting to slowly recover. And one of the things I've heard recently today, and I think I saw one of the slides, but is this called it enterprise case management.
Yeah.
And so, I've heard, should we be centralized, right? Because when you think about, I remember one of you said this too, you might have had 250 case managers, but then they're all calling the patient and they're all asking the same stuff.
Absolutely.
The more I've been, it's really just been like the last week, I'm thinking, why don't we kind of think more centralized on a lot of stuff?
Yeah.
So is that
Yes.
the direction people
Yes.
think that we're going to be going?
Yeah.
Yeah. Well, yeah. And Cynthia, please jump in because I want to be
Absolutely.
expertise.
I think one of the most critical aspects is, again, understanding how many you have, and then, being very clear about roles and responsibilities. And so, and in order to accomplish it, I mean, you can do it in a matrix, but you've got to, you've really got to, it depends on your organizational culture as well. We recommend just a very strong set of job descriptions, strong education and support, and certainly having very clear metrics for each one of the care managers that's in the program as well, because you've got really good folks in care management roles. Oftentimes, though, they've been folks, I have plenty of gray hair, trust me, and have worked in their roles for a number of years, and so taking them through change management process to help them be comfortable in providing them support in new ways of doing their clinical practice is very key as well.
Yeah. And that is when we think about enterprise care management or enterprise case management, whatever verbiage a team's using, that to us is a foundational element to build on these innovative care models. So if that's not working well, focus on what you can strengthen and then come in with some innovative care models, because that enterprise-wide approach to care coordination is going to make it's a differentiator on how successful your care models are.
I think one of the things that's come up recently is social insurance, right?
Yes.
We've been talking about that for several years.
Yep.
And now all of a sudden people are getting on it, right? They're
Yep.
like, okay, we gotta do this like now. We should have been proactive like a couple of years ago.
Yes.
So when you look at that, it's again, I feel like ambulatory's trying to do it, accute's trying to do it, health's trying to do it.
Yep.
And we're kind of trying to do it together, but we're not really there. And I kind of
Yes.
just feel like we need these overarching big
Yep.
teams from the organization, not these silos.
Yes.
And I mean, we are kind of like, kind of bringing them together because I happen to know the different people.
Yeah.
And when you do that, but if you don't, you see the silos.
Yes.
And they want to talk to each other. It's just that everybody's got so many priorities.
Yep.
It just seems like, and I'm not sure what this is, but I think something's happening in January, Biden and the administration, something else with equity. Anybody? Somebody was saying that in one of our social terms. So I'm like, okay, I have to figure out what that says.
There are a lot of
talking about this today, so I don't know.
Yeah. I ultimately though, it's harness the power of the talent you have together and you can do more.
Yeah.
Yeah.
Exactly.
Yep. Yeah. Any other questions or Cynthia's on the, oh, please.
I don't have a question, but Cynthia Dana Summers here. Hi. I just wanted to say, this is a topic near and dear to my heart because I've lived with an elderly patient, parent through this. And I think it's a really great stride forward. And I want to thank you all for doing such a great presentation.
Oh, thank you. Thank you. And thank you to Cynthia, who is on the East Coast and who clearly has gone into her dinner time to be here with us today. So, yes, cheers to you, my friend. Do you want to say hi to Dana? Cynthia,
Dana, I would love to say hi to Dana. I'd love to see Dana. Thanks.
Stop recording.